I'd like to introduce Chris Hess, Dr. Chris Hess. He is a neuroradiologist. He's from UC San Francisco. And I just want to take a few seconds to say what a neuroradiologist does, because they look at pictures of the brain. And with each child that gets imaged, there's how many pictures? 70, 100?
Nowadays, we're talking about 1,000 images.
1,000 images. And so Dr. Hess has spent a lifetime looking at children that have PHACE syndrome. He's looked at more images than anyone in the world with this diagnosis, and multiple images of many of your children here, and has just had an incredible time commitment looking at the images as well as thinking about them and helping us as physicians interpret those results into talking to parents, as well as helping to make guidelines for other physicians as well. So he's just been a huge help in our journey with PHACE syndrome, and I thank him very much for his time yesterday and coming to speak to us today as well. I'm going to get your talk up here.
Thank you, Beth. Well, this talk is a departure from some of the other talks. I recognize some familiar faces from Texas, in fact, from 2 years ago. Can you hear me in the back if I just kind of use my voice like this? Okay, good. This is a medical talk in the sense that I'm going to be showing you a lot of images. And the kind of impetus behind it was some of the questions that you've asked, number one. And number two, I think as concerned parents, probably some of you have seen the images or seen the reports even, and kind of wonder what they mean. So the goal here is really to take a step back and say, A, what is the meaning of these findings? What are the findings, number one? And number two, to take a step back and look at the kind of general physiology and try to understand what's going on, how blood gets to the brain, and then hopefully give you a better idea of what kind of the spectrum of abnormalities that we're looking at. And I'll touch briefly on the clinical implications. So in the next 30 minutes or so, the way I've structured the talk is first we'll review the circulation of the head and neck, and that's how the blood gets from the heart to the brain through the 4 vessels in the neck. And then we'll go through a series of arterial anomalies. Anomaly, if you look at Webster, just means something that's different from the normal. So we're going to look at a series of anomalies, all from PHACE patients. And now that I'll explain some of the anatomy and some of the pictures, you'll get to make the diagnosis yourself. And then just briefly, because this is really work in evolution as kind of the inspiration for this conference and the last conference in Texas, we'll try to discuss some of the potential clinical implications. I know that's where your questions are, and that's certainly where our questions are as well. Because I'm leaving, if there are any burning imaging questions, I'll list my email at the end, first of all. And second of all, if you do have a burning question, feel free to raise your hand. And if we do need to, we'll discuss afterwards. So I'm a radiologist. I'm very comfortable looking at images in the dark without going to sleep. But if you're going to sleep, I want to start with this message. Okay. Imaging helps us to identify and describe arterial anomalies, but it doesn't tell us anything about what's going on under the microscope. That's the bottom line. If you look at the head and neck, it's very interesting. The heart itself is a very active pump. It pumps throughout your lifetime. 20% of the blood, delivering the oxygen and the nutrients to the brain, goes to the brain, and the brain is only about 2% of the body weight. So it's a phenomenally, incredibly metabolic organ that takes a lot of blood to get there. If you look at what's going on in the neck, there's only 4 major arteries in the neck that go from the chest to the brain. There's a carotid on each side, and there's a vertebral artery on each side. And that's shown in this Gray's Anatomy from the 1800s. This is your carotid artery, and this is your vertebral artery on one side. You have those each on one side for a total of 4 vessels. And then there's 2 major veins that drain the heart, drain the blood once it's gotten to the head. It drains it out the neck and back into the heart so it can be pumped in a circle. To get just a little bit more complicated, this is, if I'm standing in front of the patient, I can see those 2 carotid arteries and 2 vertebral arteries behind. I think it's important to kind of get a road map of the anatomy before you look at the images. So this is standing in front of the patient. In the neck, I have the carotid vertebral arteries. Once I'm in the intracranial circulation, it gets a little different. The 2 vertebral arteries come together to form a basilar artery. Those 2 divide and become the posterior cerebral artery. And in the front, the 2 internal carotid arteries divide into anterior and middle cerebral arteries. So a lot of words there. zoom up and just try to, this is in your syllabus if you'd like to refer back to it. This is kind of looking from the top down now. So the center of the brain, if you will, or around the midline, is supplied by the two anterior cerebral arteries, we call those ACA, and the sides of the brain are supplied by the MCA, and then the basilar artery is constituted by those two vertebral arteries coming together, and that supplies mostly the back of the brain. One thing that's unique about the intracranial circulation, if you look at it very carefully, there's a circle there. So if you're missing an artery, or one artery is abnormal, many patients will have blood that can go around the circle to feed other arteries. The complicated part is we're not all created alike. So not everybody has a complete circle. So you could be missing your anterior communicating artery, that's called ACOM here. You could be missing part of your PCA, you can be missing your PCOM. And so those circulations become somewhat independent and separated from this whole circle. So if you have a complete circle, it's actually possible, and I've seen it, usually an atherosclerotic gentleman, I'm sure Dr. Orbach has seen it too, in their 70s who've been smoking all their lives, so a little pitch, just don't smoke, but they have one artery, one vertebral, supplying their entire brain because the other ones have occluded because of their disease. So it's certainly possible. When you look at medical images, it's very important to try to understand where they're coming from. When we talk about three planes as imagers, the coronal plane, the axial plane, the sagittal plane, when you look at angiography, angiography is the way to image the arteries of the head and neck or elsewhere in the body. The axial plane is kind of looking through the patient from the bottom, if you will. So we see, just like we did on that other image, the MCA, the middle cerebral artery, the ACA in the middle, there's two of those, the ICA supplying both the ACA and the MCA, and then back in the back, the basilar artery comes up and supplies the posterior cerebral artery. This patient does not have a complete circle of Willis, as is most commonly found. So this is the axial plane looking up through the patient's head. I've taken a volume of images, and I look all the way through, and I pretend I just want to look at the arteries, and I'm left with that image. The coronal plane, now this is an angiogram through the neck. You're standing in front of me, you're looking through my neck. You look at the arteries that go up in the brain. Here's the aortic arch you've heard so much about. These are the common carotid arteries. They become the internal carotid arteries. They feed the brain, you can see here. Behind that are those two vertebral arteries. Those are those four vessels. These are veins, these more faintly dancing. So that's kind of the landscape that we're dealing with in this situation. So the first question that I'd like to address is, first, what is actually seen in vascular brain imaging studies on PHACE? I'm going to throw these medical words out there just so you can have them because you're going to read about them or see them. I'm also going to give a little description. I like to think in terms of analogies. This is not in your syllabus. I've added this, so if you do want a copy of this, feel free to email me. I'd be happy to email it to you. You can think of during the process of arteriogenesis or vasculogenesis, blood vessels try to get from point A to point B. And point A may be the heart, and point B may be the brain. And the normal pattern, if you will, is kind of like a roadway system. Blood is set up along roads, and it will go from the chest to the brain along a 4-lane highway, a nice straight vessel, we'll pretend for the sake of the analogy. If I have an arterial dysplasia, or what we call DisGenesis, because it developed abnormality, the contractor may not have gotten the plans too well, or the person who's paving the road really didn't work out the plans too well, and they know they have to go from point A to point B, but the road is not too great. It's got a lot of bumps, it's all over the map. We're trying to figure out there's no normal 4-lane highway, there may be an 8-lane highway through the middle. That's the general idea of dysplasia. When we have aberrant arterial course of origin, you may have a normal 4-lane highway, but instead of going directly from point A to point B, you may deviate just a little bit from what we're accustomed to, or what we call normal. Arterial narrowing is just what you think it is. Instead of having a 4-lane highway, you may have a 1-lane highway or a 2-lane highway to go from point A to B, and that can be a long segment narrowing, or it can be a more focal narrowing. You have a 4-lane highway, but suddenly you have to squeeze through a bridge, and it goes down to a 1-lane highway. That's focal narrowing of that artery. Then we talk about non-visualization. On an angiogram, that means I can't see the artery. That's pretty fancy scientific talk. So my 4-lane highway will go from point A and may stop. I don't know if it's there or not. I just don't know. I know that I don't see it on imaging. And to make up for it, very often you'll have other pathways around that. And that may be through that circle of Willis that we mentioned before. It may also be through other anomalous vessels that kind of take the place of the arteries that we usually have. And then persistent embryonic connections, as that pattern of arteriogenesis is going on, in order to build from point A to point B, you may think of, like, when you make a road, you have to have detours to start out with. So we may start out with this system where the constructors or the road architects have to go to point A and point B from a major highway in order to pave the road from point A to point B. But they get to their locations, they don't have any cement, they decide they're not going to do it, but they still want to maintain that road, so they have an embryonic connection between point A and point B. Does that make sense? It's kind of a little bit hokey, but that's the general idea. So as far as arterial dysplasia, if you read papers on PHACE, there's a number of terms that are used. I personally think a picture's worth 1,000 words. It's really hard to describe with adjectives what they are. I've put arrows on some of these anomalies. But you can see this is on the left side of the brain. There's a normal, this is the ICA. I'm standing in front of the patient. I've labeled this coronal. And on the right side of the patient, you can see that 4-lane highway, maybe at 5 lanes, it's a little bit loopy all along. So that's what we call DisGenesis or dysplasia. It becomes a little bit more complex in the case below. The road is more curvy. A couple more cases. You can see this one is an axial, so I'm looking down from the bottom. Some bumps in the road. The normal arteries are smooth along their course. These arteries are irregular around the edges. So that's DisGenesis. Aberrant course we talked about. This is where we have the normal arteries. Somebody had the plans right, but they didn't have their compass. So if I look at the normal lane from the top of the internal carotid artery to the ACA, a nice horizontal line, but you may have a little loop. A couple more examples of that. It just gets a little tortuous. Here's a great example where the artery is looking pretty normal, but right before it goes into the skull, it does a loop. Narrowing, as I mentioned, there's kind of a change in caliber. A normal artery gets smaller and smaller as you get further and further from the point at which blood flow starts. At this point, we see it get narrow and they get big. That's a focal narrowing here. This is a coronal image. Here in the neck, you can see this is a long segment narrowing. The whole internal carotid artery is narrow if you compare from side to side. This is the left, this is normal, and on the right it becomes diffusely narrowed. Non-visualization, example, I'm looking from below, I see the ICA, the MCA. On the MCA on this side, I'm following out, the road just stops. I know there's some connection more distally to the MCA because there's filling with flow, so I know that there must be a road there, but I'm not seeing it. Not only that, but if you look carefully, you're missing the whole ICA on that side. So you can see where radiology becomes kind of like a game. I'm looking at a puzzle. So does anybody see anything abnormal about this picture? Stunned into silence.
I'm not cheating being a retired physician.
Oh, well, you're not fair. So if you look carefully side to side, I'll tell you this is the basilar artery. Look on this side. What's missing on this side? There we go. The internal carotid artery is not visualized. All right, now I'll let you take this one, sir.
Left subclavian.
Yeah, it is a little narrow.
Vertebral.
Well, we have both vertebral arteries, right, because they come within the basilar artery.
The left internal carotid artery.
You got it. Unfortunately, my mouse does not. So that left internal carotid artery is not visualized. That could mean two things. It didn't develop, or at some point it occluded, and you have a circle of Willis upstairs which supplied flow and it is completely silent. We don't know. It may have occluded in the uterus. But not, either way on imaging, we don't see it. So when you see the term non-visualization, that's what you're thinking of. And I don't want to belabor this too much, but you can also see these primitive roads or these detour pathways that you can also see on imaging. Those are normal pathways. It's important to emphasize everybody has a programmed system of development of arteries in the brain. And when something goes awry for whatever reason, you may need that blood. So that artery that usually goes away because you've built the road will stay there. So that's what these primitive arteries are. And those are just some of the names you may see. So what are some of the more common abnormalities? We just published a study on 70 patients. There's a Jeff Heyer did a large study in 100 patients from a literature review. The numbers were a little bit different because of the way we acquired our patients, but I thought it was very interesting that the type of anomaly is actually the same in terms of frequency. So the most common anomaly that we saw was dysplasia, or DisGenesis. And then moving down from there, course and origin, narrowing, non-visualization, and PEA is persistent embryonic artery. So that's kind of what we're looking for. This led to the development at the Houston conference that was mentioned earlier, to the development of diagnostic criteria. If we have a patient with segmental hemangioma, how do we decide if they have PHACE? We looked at most common arterial anomalies, and those actually that I just discussed would show up in the definition. Okay, question number 2, I think, are some arteries somehow more vulnerable than others, or can PHACE occur just in about any artery? Well, I don't think the answer to that is really known, but I can tell you empirically, when we look at the data, it definitely involves more than, it involves some arteries more than others. And not only that, but most of the time, there's not just a single anomaly present, there's more than one type of anomaly present. So 2 examples of that. This is what we found in our study. The internal carotid artery was the most frequently involved artery. It's also one of the most important arteries. And just for showing of hands, how many of you have heard of the internal carotid artery because of your child's report? A lot of people. So that's a very frequently involved artery. After that, probably the MCA, the ACA, the PCA, things like that. But the ICA is very frequently involved. And here's a child. This is a 3-dimensional rendering, but I'm standing in front of the patient. If I look very carefully, I can see a dysplastic or a dysgenetic segment of the internal carotid artery. I'm missing the entire internal carotid artery on that side if you look carefully. I look at the other side, there's an abnormality. The MCA is narrowed, so I have narrowing, dysplasia, anomalous course, non-visualization, all in one patient. So that's fairly typical. So these terms, I have to emphasize that the terms that we use, non-visualization and anomalous course, they don't describe the pathophysiology of the disease. So they're probably just variations on a theme in the sense that arterial dysgenesis may arise during the patterned development of the arteries and secondarily cause arterial occlusions and things like that. And the actual pathology may be related to an abnormality of the vessel walls and then also to an abnormality that in blood flow that results from the abnormality in the vessel walls. That's our best guess at this point. So what are the potential complications of arteriopathy? Well, many of the cases that we've seen are actually completely asymptomatic. You'll have it on a report, and it may worry you, but it actually has no consequence whatsoever. Other symptoms that have been described in PHACE, probably related to vessels, include headache, maybe developmental delay, seizures. These are all things we're looking at now. Now, the one we worry about the most is this progressive arteriopathy. You may have heard of. When we image, it's just a snapshot in time. There's a subset of patients whose arteries get worse over time. And that's, I think, every parent's nightmare. So we're doing our best to try to figure out who that is, who that subset is. So I wanted to say a few words about this progressive arteriopathy. Number one, anything we say is just our best guess at this point. There are a number of reported cases. Our general feeling is that the incidence of stroke is relatively low among patients with PHACE. In fact, it's probably much lower than we initially thought. There's some literature pointing to the fact that, I guess initially, that in the worst phase of the hemangioma, when your hemangioma was proliferating, that's your most risky period. We don't know that for sure. We don't know. That's probably more risky, but not entirely clear on that. And there's really no known clinical or imaging predictors. So at this point, I would tell you just to stay tuned. I did want to mention these 2 reports. These are both retrospective studies. Just to emphasize, retrospective studies are limited by the fact that we acquire patients. You can imagine, what are the most interesting patients? Let's find the worst cases. And then you look at those. And then it becomes kind of diffused through the literature. Wow, everybody with PHACE gets stroke. Not the case. But one thing we did notice is All of the cases had narrowings or occlusions, so that's something we're looking at more carefully now to see if these children progress. Moyamoya is another term I wanted to mention because of the association in literature. Moyamoya you can think of as a type of narrowing of an artery. When it occurs very slowly over time, vessels around that artery will take over the blood flow. So the Moyamoya phenomenon is just the taking over the blood flow by these collaterals. So if I look in this case, unfortunately I lost my, oh there it is. You can look at the internal carotid arteries. I'm standing in front of the patient. In fact, you can just barely see their eyes. It looks like Darth Vader, but there it is. The internal carotid arteries just end. We're missing a segment of that MCA. We're missing a segment. Those are narrowings or occlusions, but what has taken over these large collaterals that will bypass that area of stenosis. So that's kind of a progressive narrowing. You can think of it like that. One of the things we've been thinking about more is the implications of medication when a patient has arteriopathy. You can think of if I dropped a patient's blood pressure and they had a complete circulation, the whole area of the brain may be at risk. If a patient has a narrowing, it may not be the whole brain. It may be the pipe that's the smallest. So that's something we've been thinking about. There's been a lot of talk in the literature with propranolol, and my goal is not to scare anybody, but propranolol has a potential to drop blood pressure. So one of the things we've been thinking about is, are there children at higher risk for dropping their blood pressure and consequently causing a stroke? And I'll give you, this is kind of a gross picture, and I'm sorry, but many of you have seen pictures like this before. This is a patient who's hospitalized. You can see her ear. There's a missing piece of her ear. That's an ulcerated hemangioma. Propranolol is probably the best treatment, although the evidence is not great, but anecdotally the evidence is good that this patient would really probably benefit from propranolol. But look at her angiogram. So now you're an expert. Does anybody see anything that would prevent me from, or make me think twice about giving propranolol? Okay, well, we'll put arrows on it. We like to do that in radiology. If I look at this internal carotid artery, this is an artery that's dysplastic. You see it has a loop-de-loop with some irregularity of the margin. As it passes up, the intensity of the image in an MRA is related to how fast the flow is. So I know flow is slowing down in this location because it's not as bright. By the time I get to the MCA, it looks pretty irregular. And I can tell you that there's no collaterals that we see here that would bypass that area of narrowing. So if this patient's blood pressure dropped from propranolol or otherwise, then you would think that this part of the brain that's supplied by this narrow pipe would be at a higher risk. So that's something we've been thinking about. So my time is coming to an end here, but I did want to conclude by saying that, first of all, arteriopathy is common. It's more common in the anterior circulation than the posterior circulation, especially the internal carotid artery. The different abnormalities that we see on imaging, that we describe on imaging, are probably related to one fundamental thing, arterial microscopic abnormalities that we're still kind of sorting through. And third, we really need to do more research to try to identify risk factors, both clinically and by imaging, that may predict the progression to more serious comorbidities. So again, the message that imaging helps us to identify and describe, but doesn't tell us about anything about the microscopic tissue abnormalities or about risk. Thank you for your time and attention.
So again, if there are questions that people would like to write down, Roy will collect those. We have many questions from the website, probably over 100 questions, and many of them are on the subject of neurologic issues, neuroradiology, and treatment for that. We'll have, again, a more extensive panel tomorrow. But Chris, there were a couple questions that I thought maybe we could touch upon today. And Darren, would you mind helping out too with a few answers to this? Is Dr. Darren Orbach, who is a neuro interventional radiologist from Boston Children's. It's been great to have here over the last couple days. So there were several questions about the significance of the persistent trigeminal artery. Can you comment on what that would be? Or maybe that would be a good one for Dr. Orbach.
There are several embryonic vessels that normally disappear before patients are born. The trigeminal artery is the most common one, and we would treat that as a normal variant more than as a worrisome sign on its own. So although it's included as one of the potential diagnostic features of PHACE, on its own without any other changes, it's not really worrisome. It's providing the brain with normal blood flow on its own.
One of the important, you said the significance, I think it is significant in the fact that it helps us to kind of cinch the diagnosis of PHACE in a way. So it alerts us to the fact that your child may have PHACE if we see a persistent trigeminal artery. But the significance of it is, thank goodness it's there because it's actually providing normal blood flow.
And then the other question was, in general, most of us are evaluating kids with PHACE syndrome with an MRI and an MRA, and when would we need to consider other sensitive, perhaps more sensitive, or other imaging modalities in a child that has PHACE syndrome?
Well, I'll say something and then you can, once you add it. In general, so there's several ways to look at arteries, non-invasively and invasively. MRA is the one probably most of you are familiar with. There's also CTA, that's computed tomography, angiography. And then there's catheter angiography when actual catheter is placed up and X-ray dye is injected, and with an X-ray machine you look at the artery with very high resolution. So there's risks and benefits to each of those procedures. The nice thing about MRA is that it's non-invasive and there's no radiation risk at all. The downside of it is if it's too young, if your child's too young, often they'll need anesthesia. So there's a small risk to anesthesia, and it's not entirely benign. CT angiography gives an exquisite display of the arteries, but it's a fairly high radiation dose, so we tend to avoid it in children. Catheter angiography is more invasive. It's not dangerous by any stretch of the imagination, but it's more invasive. It's a limited resource. Darren likes to go home at night and see his kids once in a while, so we can't do it on every single patient. So the normal course of events is to look on MRA, and if there's any kind of troubleshooting you need, then you think about the next modality. Do I need a CTA? Do I need a catheter angiogram? And often that will come in the acute setting. So if there's a change in something that could be attributable to the arteries, then you may want to do an angiogram. Or there may be an abnormality we're just trying to tease out, is this really significant? Is there a reduced blood flow to part of the brain? In which case, we'd have to do a catheter angiogram.
And I would very much agree with that. The images from MRA these days are so good that can answer most questions. CTA in most cases does give a higher resolution picture, so that would usually be the next step. Catheter angiography can be technically challenging in very young infants, but it certainly can be done safely, but it certainly requires general anesthesia. There are increased risks compared to MRA or CTA. But I would think of it more as when there's been a change or when we're contemplating potential treatment, then there's really no replacement for a catheter angiogram, because it allows us to inject each vessel on its own and see what the blood flow distal to that one vessel is, whereas CTA and MRA give us a global picture of all the vessels at once, as you saw.
One last question. So this was probably the most common question, and I think just with the caveat, with your experience of looking at probably more films of children with PHACE syndrome, many people are wondering the frequency or probability of ongoing stenosis of the A of PHACE versus more of a static congenital malformations. So, and what's your gestalt?
I knew Beth was going to ask this question when I was presenting it. So in our experience, narrowing is a fairly frequent anomaly, as you saw. The question would be, to what extent is that progressive over time? We're currently doing that study, so I can't tell the exact answer. Anecdotally, the number is very small.
Yeah, and this is purely intuition because we really don't know the answer yet, but my sense is that in most cases the narrowing is static and it's just abnormal anatomy that will persist throughout life, but it does seem to be a subset of patients in whom there are progressive issues. So We're still trying to figure out how best to screen everyone in order to identify that subset who do need an intervention, but it really is a guess at this stage.